So I'm Steve Ball. I used to work in Newcastle with Margaret, and I no longer work in Newcastle with Margaret, and I now work in Manchester. But still feels very new to me. So new, in fact, that embarrassingly, when I came to speak this morning, I said, "Why have they named a room after a Spanish house?" Which I was immediately, shown up to be the Manchester newbie, because obviously it's not named after a house. There's a whole music theme going on down here. Yeah. Yeah. So it was before my time. So we've got an hour altogether. The first bit is meant to be about research. I'm going to struggle to stand still. And then we're going to move into a little bit on how to assess research evidence. But really the two things are very blurred. And I'm very comfortable having this as interactive as possible. Because I really don't want to stand up and just talk, if that's okay with people. So what did the Romans ever do for us? Apart from roads and sanitation and schools and language, and what did research ever do for us? Moment. So MEN and SDH-related conditions and adrenal cancer are rare conditions. What's the big problem with rare conditions? They're rare. And so if we, in 2017, want to have evidence-based treatments that work, we have to have evidence. Evidence is based on research. It's hard to do research in rare conditions because they're rare. But we are where we are. And we're in a particular place in the UK that's somewhat different to other parts of the world in terms of how we've organised our healthcare over the years. So there's certain things I have to say, don't want to out anyone, but this is the moment where anyone who voted for Brexit can leave if they want to. We're slightly less good at certain things than some of our European colleagues. So for the last 20 years, there's been a French-German collaboration for familial paraganglioma. So everyone with a paraganglioma in France and Germany is part of the patient registry. For the last 40 years, there's been a German-based adrenal cancer network and an adrenal cancer registry. And for the last 20 years, there's been an emerging MEN registry across Europe. Why? There's been a registry for all of those rare diseases because the European colleagues some time ago recognised that the only way we're going to generate an evidence base and do research in rare diseases is if we know where everyone is who's got one and know what treatments they have and measure what happens. There are certain advantages to the way that the Europeans have organised their healthcare that means that it's easier for them. In France, if you have a pheochromocytoma or a paraganglioma, until the last 5 years you are treated in one of two places. One of which was Paris, one of which was in the south of France. If you were in Germany and you had adrenal cancer, you were managed in one of two places. And as the physicians in those two places trained with each other and knew each other really well, the treatment approaches were the same. The UK has got a different system. Historically, we've felt that was a strength. We've gone for competition rather than cooperation. We've gone for standalone institutions with autonomy rather than collaborations. To succeed in a competitive, autonomous system, we've recruited people to work in those institutions that have particular characteristics. They're competitive, they don't collaborate, and they work autonomously. And we now find ourselves in 2017, especially in the field of managing rare diseases, that we have institutional approaches and individual approaches that are maybe less fit for purpose than we would wish. And we need to think about changing that. And that will be one of the recurrent themes during the first part of the talk. But we are where we are. The question isn't really where we are, as much as where we want to be, and how we're going to get from where we are to where we want to be. And where do clinicians and professionals fit in, and where do patients fit in? So I guess in any field of life, not medical research or biomedical research or biomedicine, if you're wanting to improve something, and that this is applicable to industry, manufacturing, education, there are three questions that we always ask around improvement or improving a process. What are you trying to accomplish? What would improvement look like? How will you know that actually it has been an improvement? What are you measuring that you're doing now? What are you going to measure in the future? How are you going to measure that there's been an improvement? And what are the possible options that you can think of out of the gate for improving things? This doesn't come as a projection very well, but part of the NHS 5-year forward view, I don't know how long we can carry on calling it a 5-year forward view when it was published 2 years ago. So it's now the 2.5-year forward view. You can only be sure of improving something if you measure it. And that's the other thing we've not been traditionally terribly good at in biomedical sciences in the UK. We've not actually been really good at measuring things. So you may go to hospital X and be looked after by clinician Y for condition Z. And clinician Y in hospital X may say, I'm the best for this condition in the best hospital. Yeah? But no one's ever really measured how good he is, and no one's ever really measured how good the institution is. Because we've lacked the metrics for doing it, and we've lacked the will to go ahead and do it. In 2017, ladies and gentlemen, we will not improve something if we don't measure it, because we won't know what improvement looks like, and we'll continue to see improvement as a static thing. I was here, I'm now here, I'm better, as opposed to I have been here, I'm moving to here, and I will continue to improve going forward. So research in rare diseases has got certain disadvantages that we have to overcome, and we need to incorporate this into how we're going to move forward as a community. We need to start to cooperate rather than compete. We need to collaborate across institutions and work as networks rather than autonomous standalone institutions. And we need to develop something around a patient-professional partnership. If we really want to be somewhere different in 10 years to where we are now, we have to start behaving in a different way. And that means that the institutions and the organisations and the clinical professionals then have to start behaving in a different way. But more importantly, we have to recognise that it's not about the clinicians. It's actually not simply about the patients either. This is a journey that we both have to actually go on, because neither can do it without the other. I used to play a lot of football when I was a kid, hence the sore knees. There's a point in being coached in football where you're told to look at the ball all the time. Keep your eye on the ball, keep your eye on the ball. Then you reach a level where you suddenly hear the coach shouting from the sideline, play with your head up. Well, how can I play with my head up if I'm keeping my eye on the ball? And no one ever tells you it's because we expect you to know where the ball is by now. So now you've got to do something else. So you do that. And then the most difficult part is when, and this is going to be a questionable ethics now, I need to be careful because there's a teacher in the room. There's a point in football training where one of the common training tools is that they tie 3 people together. Sorry, it sounds like my ex-football coach is going to be up in front of the child protection people now. So they tie 3 of you together with rope, loosely, and it's a metre long, and the idea is that you've got to work the ball down the field, and you've got to stay within a certain distance from each other, and you've got to pass it. And what that's meant to teach you is the only way you can get this ball down the field is to work cooperatively. And you really begin to see some people who are absolutely stonkingly brilliant as individuals on the football team. They could never get this because they always want to run faster than anyone else. They want to have the ball all the time, and it never works for them. I think, ladies and gentlemen, 2017, if we want to do this thing with rare diseases, we have to become really good at working tied up together, working the ball down the field. Otherwise, we ain't going to get where we want to be. So what would that really look like in terms of ACC, in terms of MEN, in terms of familial paraganglioma? Well, we've got some catching up to do. We've got some catching up to do in terms of learning what's gone and worked well in Europe. I had a meeting with people in Paris some 5 years ago saying, can we join your consortium, please? And they said, no. I said, well, kind of, why not? And they said, because you can't play nicely with each other. Why would we want you? Why would we want you in our club? Yes, you can't even cooperate among each other. Why would we want you here? And I'm thinking, is he talking about the EU or is he talking about cooperation? So we have some catching up to do because we don't have a tradition of working like that in the UK. On the immediate horizon is a patient registry for those with MEN and neuroendocrine tumours. And that will be a way of not getting everybody with this condition to come to Clinic A, because the clinician who runs Clinic A likes collecting stamps. That's the Bart's moment. You can see I've got some baggage for Bart.
You have a little bit,
yeah. The only reason I'm balanced is that I've got a chip on both shoulders. It's about working as a network. To work effectively as a group, we don't have to have everybody in one place. We just have to play nicely in the playground together, and we need to learn to do that. We have to do something with that information. Everyone with adrenocortical carcinoma or an adrenal adenoma in the UK is now eligible to be registered with the European Network for the Study of Adrenal Tumours, NSAT, and we would like to support individual institutions and their patients to input data into that registry so that we're learning as we're going along. And patients with pheochromocytoma and familial paraganglioma are also able to be entered into the NSAT registry, so that, again, in 10 years' time, we aren't still in the same place talking about the possibility of sharing data. We've had 10 years of sharing data and learning. And that was the big pitch. Does that ring true with anyone's experiences, or does anyone have any questions about that?
We research done in Switzerland on identifying insulinomas within new systems. I know some of the funding was from the NHS, they had joined in party to it. But it was very interesting that the lead doctor, and they're very clever, that you only meet really one doctor, even if there's this massive team out with you, physically working with you all week. There was clear evidence with the way that he was trying to make sure about being fed the information back post-operative. How uncertain he was that he would ever get results of, well, we've done all this, what was the histopathology afterwards? And it's like there was documents to be signed, but even then he was sort of saying, oh, stay in contact, there's the details, send us bits, and you send him updated information. But even to this point, we don't know if he's actually physically received
the
results from
information
here.
he was promised.
Yeah.
And that's a big problem, isn't it? Because there are lots of obstacles, if not barriers, to doing this. But we're not going to overcome any of those unless there's a willingness to actually do it. So some of you maybe have already heard about the big work going on in London around, it's going to sound really science fiction-y, with Google and DeepMind. Because there's some wariness from a patient perspective about who's going to get your information and what are they going to do with it and how they're going to use it. Yeah. So at the Royal Free and UCL, anyone who looked after here at Royal Free and UCL? Well, they're really into DeepMind and Google. Yeah. I don't know whether you've had to. So Google have developed this thing called DeepMind, which does sound like a Douglas Adams thing. I agree, but it isn't. DeepMind is machine learning. It's a big machine learning program that takes large chunks of patient data and looks for patterns. And what it's trying to do is look to see if it can predict outcomes and trajectory in illnesses based on patient characteristics going in. So there's a lot of information goes in to DeepMind. And the question is whether you're aware of all the information going in, have you consented to all the information going in, what use is it going to be put to? Some of you may have been approached over the last 5 years about consenting to your patient details going onto the NHS spine. And some people opt in and some people opt out. This is a smaller version of DeepMind. This is, can we share information that's not identifiable to an individual, but can we look for patterns over large populations over periods of time? And there are certain, that's not a neutral thing. Yeah. Do you want to have your information available or don't you? How certain are we that it's secure? How certain are we that people are only going to use it for research? All of these obstacles. So we're at the very beginning of doing that. The NHS has set itself up as a research-friendly organisation, but those of us who work within it and those of us that have experienced the service user end of it, you can immediately see the problems. How many times do you go to a clinic, for instance, and your notes aren't there? Yeah. Electronic patient records. We've discovered whole new ways of screwing up. The good news is we don't need your data anymore on pieces of paper. The good news, we've found a whole new way of making mistakes now in electronic patient records we'd never have thought possible.
Actually, it's interesting because, again, this goes back to the research in Europe. The actual data sent from Switzerland is incompatible with the NHS system and is on a separate system. Therefore, only if you've got the passcodes in Royal Free to get into it. So only one doctor we know actually can see it, and it has to be phoned to ask to be permission to open the files because they're locked in its private area.
So all of these things are obstacles to overcome. But I would encourage you to think very seriously if you're approached. We were talking in the small group session this morning about about disease-specific clinics, MEN clinics or paraganglioma clinics. What's the real added value? Well, the real added value from a research perspective is that we've got everybody under one umbrella, and we can encourage people to be recruited to studies. They can contribute, they can influence the direction of the studies. And I'll be talking to you in a minute about what that really does look like and why that's really valid. And that's a real added value of having disease-specific clinics. But it doesn't mean you have to be in a disease-specific clinic. If the professionals in the institutions network properly, we actually don't need you to be in Clinic X in City Y. We just need everybody to be linked in and involved in a network. One of the mantras that we had that we talked about this morning was the best possible care as close to home as possible. And that's about trade-off. If you can get best care close to home, that's what I'll have. How far will we travel to get care that's better? That's a trade-off. So one size fits all isn't going to work, but networking is the way forward. Collaboration, cooperation, and partnership. Who reads research articles? Yeah. Who reads anything? Are you? Do you? What newspapers do people read? Let's not go there. Okay. But I was watching an advert on the telly the other night. It said, the Daily Mail is now 10p cheaper than the Daily Express. Buy the Daily Mail. I'm thinking, I always wondered why people read the Daily Mail.
Don't believe it.
Don't believe it. There you go. Yeah. The reason I bring up newspapers is that you choose your newspaper and you tend to be relatively loyal to it. Yeah. And you buy that paper for a reason. Either you like it, or you like the size, or you like the style, or it's got the right content in it. How many, if you read a story, do you then say, I'm not sure about that, and go out and buy 5 different newspapers and read a different article based on the same topic? You do. Oh, God, there's always one. So my father-in-law was from Glasgow. He's Glaswegian, and he used to say, you should watch the Middle East news broadcast, because he reckoned it was the least biased of all. Really? He's from Glasgow. He said, no, it's by far, Al Jazeera, he said, is the least biased news channel.
It's almost number 1 in the world for reliability.
Yeah.
Britain's 40th, by the way.
Whereas, I admit my bias. I'm like, I used to be told I couldn't watch ITV because it was bad for me. Imagine the pressure as a teenager to watch ITV if you're told it's bad for you. I was like, I'm gagging to turn it on just to see what's on. Actually, I was really disappointed. It's like, I guess what I'm talking about is bias. You choose to read what you read from a certain source, and you don't triangulate that often, and so that's a bias. It's not it's a conscious bias. You are consciously choosing to do that, and that's going to be a theme that we bring up when we're dealing with medicine, because there's a conscious bias and then there's an unconscious bias when you're talking about evidence. What determines clinical practice, do we think? You come to my clinic, what do you think dictates what I say to you and what we treat you with?
Resources?
Well, that's what we think. My opinion is we should do that. There's experience, this is what I've always done. Yeah. Then there's evidence, what we know. Yeah. Now, wouldn't it be brilliant if my opinion, based on my experience, is actually all based on evidence? Because that would be best practice. Yeah? There's an explicit assumption that my opinion and my experience reflects evidence, and that I'm going to give you best practice. We need to think about that a little bit, because that is an assumption. Because my experience is my experience. It may be contrary to what the evidence is, but it's been my experience. If you ask people what would make you change your newspaper? Well, apart from 10p going on the price compared to the other one if you're a Daily Express reader. There's something called assimilation bias. Assimilation bias talks to if person A believes something different to person B and they have a conversation, person B tries to convince person A of their false view by giving them more information, because person B believes that person A doesn't think the same as them because they don't know enough. So by giving them information, they will convince them otherwise. That's almost certainly not the case. Person A doesn't believe what person B does, not because there's an information deficit, but because they view the world differently. And just giving more information isn't going to make them the same. So if my experience as a clinician is different to the evidence, I might not change my opinion, because I may be someone who's more driven to behave in a way that's based on my experience than on what the evidence is. And you may be the same as patients. If I say treatment B that you've been on, treatment A that you've been using for the last 15 years has been shown not to be of any benefit, but you're feeling okay on it. And you were told 10 years ago, by the way, this is what you should be on. You're now faced with a dilemma of who do you believe? Do you believe the person who told you 10 years ago this was the bee's knees? Do you tell me who you just met for the first? Do you trust me who you've just met for the first time? Do you go away and independently review the evidence? You're being given two conflicting pieces of information. And me going on and on at you about what the evidence is might not change your perspective, because your perspective may be one of experience. You've experienced this for 10 years and you've been fine. Why should I change? It's not broke, let's not fix it. So, how do we assess evidence would be a question. Do we just read one article in the Daily Mail and say that must be the truth? Do we get the Daily Express and the Daily Mail and the Daily Telegraph, knowing that they're somewhat towards one end of the spectrum? Read those, they're more or less the same. Do we buy 20 newspapers and read the same topic and then decide? And if you were to do that, how do you weigh up which is the one that's right? If they're all saying the same thing, that's probably easy. If they're all saying somewhat different things, how do you tell? How do you weigh up which is the one you're going to believe? One would like to invent a tool that allows you to make that judgment, to make that balance. Well, there is a tool, and it's called the grade tool. What does it do? It provides a standard framework for assessing the quality of evidence that you might read. Why is this important to you? Well, you may want to think about this, but more importantly, you may be on the receiving end of this, because when NICE, the National Institute of Health and Clinical Excellence, makes its recommendations on what we do and what we don't fund, what we do and what we don't recommend, it's based on this tool. And if you don't understand how the tool works, you will not agree necessarily with the decisions that organisations like NICE make. So it's important we understand what these rules are. So it provides a standard framework for assessing the quality of evidence, and that makes and encourages transparency, so we all understand why the decision's been made. It provides a systematic way of saying, not only does this look as though it works, it gives an idea of the impact, or how big an effect is it, and say you might write a headline that says drug X prolongs life. Absolutely true. What you might want to know is drug X prolongs life for 3 days, or 1 day, or 24 hours, 3 minutes. So there's a whether an intervention works, and then there's an effect size issue. The two are different. And what the systematic tool does is it enables confidence in the assessment of the quality and effect of the size. Is the effect real, and how big is it? Because it takes into account the limitations of the study. How many people was this done on? What were the age of the people? How many clinical trials do we do in 2017 that recruit women, for instance? 50% of the population? 10% of drug trials involve women. So if you have evidence-based medicine, there's hardly any evidence that any drug works in women because there's no trial data using it. How many drug trials do we do in children? How many drug trials do we do in people over 75? So nearly all drug trials have been done in men between the ages of 18 and 40. Because they're the biggest people to be recruited to drug trials. How extrapolatable is evidence? In precision, how certain are we that the size of effect that we've measured is real? You might say, well, 10 years or 11 years, it's still a long time. No. Is it consistent? Do all the studies show the same direction of travel? And then there's this thing called a publication bias. Because, of course, what's printed in your newspaper is what's printed in your newspaper. You don't read what's not printed. You might think, what's that got to do with medicine? It's much, much more likely that if I do a study and it shows a positive effect, that it will be published and someone will read it and it will go into one of these tools, than if I do a trial that's actually maybe much bigger, involving much larger numbers of people, but doesn't show an effect. That's much less likely to get published. People are interested in it. It doesn't sell newspapers. Actually, it's the same in medicine. It doesn't sell journals. So there's a whole publication bias towards positive results. So when you're looking at evidence as a patient group or as an individual, you might ask, well, it's a stepwise process. You might ask, what are the outcomes that you're really interested in? That might sound simple, but we'll see in a minute why that might be actually not as simple as you think. I have MEN1. I'm looking at a trial. What outcome am I interested in? how do you assess the quality of the evidence? Is it a good trial or not? And how do you develop a recommendation based on that evidence? Is it really going to change your view? Are you going to recommend it to someone? Are you going to recommend it for yourself or not? So why I spent some time at the beginning talking about your role in research was partly to do with this slide. You might take it as an explicit assumption that what's important to the researcher is the same as what's important to you. That might not be correct. What's important to me might be the same as what's important to you, but your perspective is going to be fundamentally different to mine because you're the person who's got the problem and I'm not. What's important to you might not be the same as what's important to me, or it may be more likely several things are important to me, several things are important to you, but the relative priorities are going to be different. And we're not going to get it right unless we listen to each other's relative priorities. That basis of prioritization has to be driven from the patient perspective up rather than from the investigator perspective down. And it's key when we then make recommendations based on the evidence. Otherwise, we're going to find ourselves making recommendations in areas that really aren't important to patients at all. And what's the point of that? So these outcomes that we think, well, that's really pretty straightforward, might not be so straightforward. So here on this slide, we've got a hierarchy: critically important, highly important, moderately important. What would be a critically important outcome in a trial for someone? And that trial might be a test, it might be a treatment, it might be a surveillance package. You might say critically important outcome would be survival. Do more people survive who've had this than if they didn't? That would probably, everyone would go tick for that one. Significant clinical events. You are developing a drug to reduce the level of cholesterol in the blood. What's the most important outcome? Well, fewer people die if they take this after 10 years. Significant clinical event. Fewer people have strokes and heart attacks. Everyone would agree to that, probably. Quality of life. People feel better on it, or at least they don't feel worse. Function. People do well in it. Activities of daily living, they're able to engage, they're at work. All of those are pretty tick, tick, tick things. But let's stick with the cholesterol lowering trial. Highly important secondary clinical problems. I don't get angina. Disease progression. My heart disease doesn't get worse. Not as important as survival and heart attacks, but moderately important, the change in the test result. My cholesterol goes down. You might think, well, that's the design purpose of the drug, to bring your cholesterol down. But actually it's not. The design purpose of the drug is to reduce death from heart disease and stroke. The way we're going to do that is to bring your cholesterol down. So it makes me feel better if the cholesterol goes down, but it doesn't actually do what it's meant to do. What I'm meant to be doing is showing fewer people die. We should not be distracted by this change in a test result, because of course that's the easiest thing to measure. I can bring your cholesterol down in 6 weeks with a tablet. Brilliant. It makes Pfizer the most wealthy drug company in the world. It's made atorvastatin the most widely prescribed drug in the world. It's made more money than any other drug ever. Not because it showed that cholesterol came down, but because it actually was associated with fewer people dying and fewer people having heart attacks. It's easy to show the cholesterol going down. It's much harder to show more people survive and fewer people die and fewer people have heart attacks. But actually it's that we should be interested in. And while you might assume I'm being pedantic, and surely if your cholesterol comes down, fewer people are going to die and fewer people have heart attacks, you would be surprised at the number of trials that have shown a change in a result. Everybody's piled in, only to discover 3 years later, more people die, more people have things go wrong with them, because we were looking at a short-term goal rather than the longer-term objective. Nearly every single drug that's been brought onto the market to reduce weight has shown an improvement in 3 months of use. They were all brought onto the market really quickly because we're all desperate for something that works. My mum used to say, don't go to a supermarket when you're hungry because you'll buy anything. Yeah? Not a single one of those drugs is still on the market because they've all been shown to have adverse effects that are worse than the benefit that they cause. None of them are still on the market. So be very wary, I would suggest, of going for the blood result. Let's be specific about MEN2. Let's talk about medullary thyroid cancer. Yeah? We have a new drug that we want to show improves the survival from medullary thyroid cancer. We know that's a long-term project. So what we go for, to keep everybody interested, is we're going to measure people's calcitonin level, and we're going to use that as a marker for success. So we give people the drug, and the calcitonin levels come down. And everybody goes, whoopee, we'll go for that, no problem. And yet, what we're really interested in is how many fewer people die from medullary thyroid cancer. What's the longer term survival? And we've been there and we've done that with a drug called sunitinib. It's very good at bringing your calcitonin down, but there's very little evidence it improves the survival. So when you look at evidence and you use the grade tool, what we really want to have at the end of it is a recommendation. What do we think we should do on the basis of this? I alluded to this morning a little bit. We can make a strong recommendation or a weak recommendation. Level 1 or level 2. And then what you'd want to know is, what's the evidence behind that recommendation? And that should be about quality of evidence. Quality of evidence, A, B, C, D. High quality, moderate quality, low quality, very low quality. I feel really strongly, number 1, that we should do this based on A, high level evidence. Would be great. I have a weak recommendation. Don't feel that strongly we should do it, because level of evidence is D, very low. Yeah? Everybody would go for that. The things we need to be wary of. I feel really strongly, level 1, but actually there's very low evidence that we should do it. Yeah? That's the Bart's moment. Sorry. Professor Besser said so. Yeah. So what does this really mean? And this is now really being very, very transparent, okay, about how biomedical science works. So level A, grade A, that's high quality evidence. 4 stars, 4 crosses. What that really means is that we're very confident that the true effect lies close to the estimate of the effect that the trial has shown. Yeah. Level B is that the true effect is likely to lie close to the estimate, but there's a possibility that actually in the real world it's going to be substantially different. Low level evidence, the true effect might be substantially different from the estimates of the effects on the studies. And level D, it says the estimates are very uncertain and often will be far from the truth. That means it's not worth the paper it's written on. There's an assumption that if it's published in a journal, that it's going to be A. But a lot of it isn't. When you unpack this recommendation bit then, and when you read in guidelines, and we should be completely transparent with guidelines for patients with rare diseases. When you see we recommend, strong recommendation, or we suggest the weak recommendation, what does that mean for patients? What does it mean for clinicians like me? What does it mean for policymakers and politicians who fund treatments and establish services? Well, if we say under the grade system we recommend, that's a strong recommendation for patients, it should mean that most people in that situation would want the recommended course of action. Only a small proportion wouldn't. For clinicians, most people should receive the recommended course of action. We should be offering that. And if you're a policy fund holder, we would recommend that you should fund this. We should all be doing this, really. We should all be aligned. But if we make a weak recommendation or a suggestion for a patient, what that would translate to, we see as most people in that situation would want the recommended course of action, but many would choose not to have it. For clinicians, it's their responsibility to recognise that different patients will make different choices based on their personal circumstances. And for budget holders, CCGs, health boards, policy as to whether we go and fund this would require substantial debate and might well not be given. So when we see recommendations of guidances for surveillance packages for MEN1, MEN2, paraganglioma treatment for ACC, and we see we recommend or we suggest, very important we recognise those words as we recommend and we suggest. Because the we recommend would mean that we are expecting most people to have this, most clinicians to offer it, and most fund holders to support it. With the we suggest, we'd be expecting many people would make individual choices. Many would want it, but some might not. Clinicians should not push this on people. They should recognise that people make different choices. And fund holders may be very reluctant to fund it. Finally, because we need to talk in a minute, for a few minutes after this. This all sounds very formulaic and very rule-bound and very rigid. And there are lots of this that is very rule-bound and rigid and formulaic. But remember that it's operated by people and there is some flexibility. The thing we go through when we're become part of NICE guidance groups. We all have to have a specific form of training around how to assess evidence. And the classic example is the parachute experiment. That you're in an aeroplane. I apologise for those who have been in an aeroplane that's crashed. We can debrief afterwards. You're in an aeroplane. It's on fire. It's at 5,000 feet. It's going down, and there are 3 parachutes in the plane, and there are 3 people. There's a surgeon, there's a physician, and there's a statistician. The surgeon jumps out the plane, basically says, "I can fly, I don't need a parachute." The physician picks up the parachute and goes, "Oh, I've never used one of these before, I'll probably be alright." Puts the parachute on and goes. And the statistician picks up the parachute and says, "Can I look at the latest randomised control trial, please?" There is never going to be a randomised control trial of jumping out of an aeroplane at 5,000 feet with or without a parachute. So there does have to be a degree of pragmatism, and what that is a very graphic example of is it's a bit like the supermarket when you're hungry moment. We would probably tolerate a lower level of evidence for an intervention that we believe to be really, really important. I can't quite believe in 2017 in medicine that we're going to accept no evidence, but we would accept lower levels of evidence for something that we believe to be really important. And so the strength of the recommendation reflects not only the level of evidence, but the importance of the outcome. And that's quite important to remember. But, and this is the last slide before we talk, because these rules and formulas are operated by people, I'm going to introduce something we talked about again this morning. It's about trade-offs. There are always going to be trade-offs. That balance of pragmatism and evidence. So the classic trade-off exercise that we do in NICE is the fast, good, cheap one. Which is the most... Pick one. We all make different choices. Do you want something that works quickly, that's cheap, or that works well? Ideally, it'd be great if it was fast, cheap, and good. The Aspen moment. Very few things that we do in biomedical sciences going forward are that easy. Fast, good, cheap. We will be making trade-offs between what we want most. Something that's fast, something that's good, something that's cheap. And we'll be prepared to trade off cost if it works really well. If it doesn't work that well, we're not going to trade off cost that much. Fast, well, it depends how urgent it is, doesn't it? If you're jumping out of the aeroplane, I want something that fixes it now moment. Something that looks to prevent this accident occurring again is really important for the general population, but it's not so important for the person on the aeroplane at that moment. They want the parachute, not a root cause analysis as to why the plane's going down. So those trade-offs will be something we have to debate as a society. And that will be something again about engaging with professional patient partnerships going forward. Bottom lines then. I've told you a lot about formulaic approaches and rules, but in the real world, assessing quality is subjective. It's subjective because you might want really, really, really very much for this thing to work. And that's going to give you a bias. And we need to be aware of that bias. I may really, really, really want this drug to work because it's going to make me famous and my career will be enhanced. That's a conflict of interest. We need to apply principles flexibly because we're in the real world and we're dealing with people. And we need to be prepared to be aware that judgment's actually quite important. And an area of judgment, for instance, would be what evidence do we include when we're doing these guidelines? Do we look at only the data that's published, knowing that there's a huge publication bias? Do we go and ask the drug companies who've done trials to say, we want to see all the evidence, not just the evidence that you've let into the public domain? Or do we just read what we're given? Mustn't throw away judgment. And I have nothing else to say, I don't think.